move on to our next session, that is Dr. S.N. Kaulgud Memorial Oration. I would like to invite respected chairpersons for the oration, Dr. B.R. Barkol sir, Professor K.L.E. JGMM Medical College, Hubli. I would like to invite Dr. Keshav Murthy sir, Consultant, Senior Consultant, Obstetrician and Gynecologist at Adarsha Hospital, Tumkur. May I call upon stage Dr. Ambarish Bandiwad sir, Professor of Obstetrics and Gynecology, Al-Azhar Medical College, Kerala. Now I request Dr. P.C. Mohapatra sir to the dais. We welcome you sir. May I now request Dr. Ambarish Bandiwad sir to speak about the importance of this oration, Dr. S.N. Kaulgud Memorial Oration. Over to you sir.
Very good morning to all. I am really happy to introduce Sir. Dr. Kaulgud is known as a Sir. He is a noble man, great human being, library of knowledge, mastery over surgery. He has a magic hands. The first person in the medical field to be honored with Karnataka Rajyotsava Award. To his credit, he has donated maximum number of times the blood, more than 30 times. Very bold to face any challenges, any complications. Very skilled person. He had a fight to teach, transfer all his knowledge and skills to his students. He was the first person to start laparoscopic sterilization training center at Chalomba Hospital with locally available, very cheap instruments like cardboard boxes and colored rubber bands. Mastery in performing vaginal hysterectomy, trained juniors and encouraged and insisted them to do vaginal hysterectomy always. He had a magic wand in his hand. His surgeries were a feast to all our eyes, very interesting and informative, encouraging junior colleagues and students to learn things. Very good organizational capacity. He organized All India OBG Conference in 1988 in Mysore. But unfortunately, we lost him in that year only. He couldn't able to see. A respected senior colleagues and offered founder president of our MOGS. And then he didn't become the president. Actually, he offered the presidentship to the senior most in Mysore, that is Madam Stephen. So that is his greatness. Though he started, he didn't become the president, he became a secretary to her. This shows her humbleness. Popularly amongst all the patients, irrespective of the religion, you will be surprised to know all the communities Chalabamba Hospital is surrounded by the Muslim community. Actually, sorry to say this, he was so popular among those Muslim women. They wanted to see, हमारे को Kaulgud sir को देखना है. This is a thing that he has popularized. Popular among all the patients, and somebody used to call them, all used to call them as God. He is such a noble person, and in his name, this oration is being given by none other than the great P.C. Mohapatra, who will be introduced by my colleague chairman.
Good morning, everyone. Dr. P.C. Mohapatra, teacher par excellence. He doesn't require any introduction to this audience, but as a routine thing, I'll like to introduce him. He is a professor emeritus obstetrics gynecology. He was past president FOXI 2011, FOXI representative to SFOG 2014 to 15, Vidya Bhushan Award by FOXI and ICOG 2021, FOXI Lifetime Achievement Award 2023, IMA Odisha Lifetime Achievement Award 2025, Academy of Clinical Embryologists Lifetime Achievement Award 2025, Satisfied Soul as a teacher, and his life mission is born to serve, living for others, working till last breath. Teaching is my passion, to be a man rather than great man. Over to sir for conducting this oration. Thank you.
Revered teachers of the teachers, my revered chairpersons, the Dean of Obstetricians and Gynecologists of all the societies of Karnataka, and the delegates of this magnificent conference, KSOGA, 35th KSOGA, organized by a team of veteran gynecologists of excellence in Karnataka. Ladies and few men, I don't know whether they are gentlemen or not. Well, at the outset, I'm really honored and blessed by all of you to be standing over here to give this prestigious oration in the name of the legendary teacher, surgeon, and academician, Professor S.N. Kaulgud. And it's really, I think, I feel honored personally. I don't know whether this is I can give a justice to this oration or not, but you have selected me as an orator, and I really pay tribute to this great legendary person as a teacher, and by virtue of experience of a teacher for the last 4.5 decades, I think I am privileged and honored today to give this oration for that. Well, the organizing committee, and particularly Dr. Durga, has impregnated me 9 months before and met me fertilized. And 9 months before he was telling that yes, KSOGA 35, you have to come and you have to give an oration in favor of a great legendary person. Thank you very much for the love and affection given to me. And in the last, I am really skeptical. I am feeling nervous after the two veteran speakers, Hafiz Rahman and Sailesh, speaking before me. I feel nervous whether I can do anything more than that. And the lovers of vagina and the lovers of umbilicus, these two persons are the lovers of umbilicus. I am one of the lover of vagina for that. I'll change my topic to this particular aspect as per your requirement for that. Well, I bring greetings from the place of Lord Jagannath. Now there are various conferences. Today itself, there was a conference. I came back from Durgapur to here. I found that yesterday and today, there are about 6 conferences in the subject in the field of Faculty of Obstetrics and Gynecology in the country for that. And if you count 365 days, all days, there are more number of conferences, particularly in our Faculty of Obstetrics and Gynecology for that. So the definition of a conference, I say, conference is a conglomeration of elite people where one alone knows nothing, and together with the group, after knowing many things, cannot do anything. But this conference is something special. This conference is something special. I went to the scientific brochure And the program for the whole couple of days for that, including the workshops and the total program, I think it is definitely different from this conference. And the preceding two lectures, two beautiful orations by these two legendary persons have explained this and justified this, that this is something different for that. Another unique quality in this conference I found out, that there are no stalwarts and there are no outstanding personality. In the stalls I visited, stalls are empty, nobody is in the stalls, and nobody is standing out, everybody is inside the hall for that. And that is the uniqueness of your KSOGA 35th, everybody will remember that for that. Well, Shova and the team has told that yes, you should be speaking on some subjects, some difficult vaginal hysterectomy and how to tackle for that. And as a gynecologist and a signature of gynecologist, I think this is very, very important for all gynecologists for that. So the basic concept of any surgical procedure, selecting the right patient for the operation, and if there are 2-3 modalities, you have to select the right operation for the patient, and third is performing the operation correctly, the skill which Silas has always emphasized for that. And last, post-op care. One of the most important post-op care is a good piece of surgery. You do it and forget it. Don't see the patient for that also. And that's important when you develop a good skill for that. And knowledge and understanding of the physiology of reproductive organs, pathology and clinical manifestations of pelvic disease, and dynamics of psychosocial and sexual development is mandatory as a pelvic surgeon, as a gynecological surgeon. I am reminded about 20 years back, there was a live workshops in Hyderabad where a general surgeon had done a beautiful TLH, total laparoscopic hysterectomy for that. Not a single drop of blood was there during the whole of the surgery for that. So the whole crowd was really exhaled for that and congratulated the surgeon for that. And I was chairing the session. Unfortunately, the surgeon wants a comment from the chairperson from me. I have to comment. I was keeping quiet. When he poked me, I had to give a comment for that. I commented, the dissection is fantastic, but the decision is dangerous. So everybody cowed, and the surgeon felt nervous for that. I told, in a 38-year-old lady, multiple fibroid of 14 weeks, yes, it's important that you are doing asymptomatic, not lived with medication. Hysterectomy is justified and laparoscopic hysterectomy is absolutely justified in this particular case. But he has chopped both the ovaries. Ovaries are normal and both the ovaries are chopped. So the decision is important. The surgery means it's not only a dissection, but the decision is important for all surgeons, maybe general surgeons, maybe gynecological surgeons. Now the glamour, fortune and commerce still evolves around hysterectomy. Complications likely, but more often with simple cases, not with difficult cases. Whatever you have imagined, that whatever complications are, most of the complications occur with simple cases, with overconfidence. If you have difficult cases, you become cautious and complications are less. Will to perform and skill to acquire is the theme for that, and no dogma in science. I think if there are 3-4 different types of surgery, either an abdominal, laparoscopic, robotic or vaginal, there is no dogma in science. Because I am a vaginal surgeon, I will do vaginal all cases. Because I am doing a laparoscopic surgeon, I am doing a laparoscopic all cases. No dogma in science for that. It is not the need of the patient is most important, not the mood of the surgeon. So mood of the surgeon is not to be taken care of. The need is important for that, and that's why you have to decide for that. And if you go to the history of these different modalities of hysterectomy, first vaginal hysterectomy is 1813. 1813 was the first vaginal hysterectomy. Then first abdominal hysterectomy in 1863. And first laparoscopic hysterectomy by Hari Rich in 1989. And that is the history tells that vaginal hysterectomy is the one oldest recorded in the history for that. So difficult vaginal hysterectomy, my talk will be concentrating on that. What are the difficulties? There are two main factors for that. One is a patient profile, another is a surgeon's profile. Patient profile, large uterus. It's a large uterus, I will not be able to do it. Fixed uterus, because of the adhesions. Previous surgeries, nulliparity, there is not ample of space in the vagina, and concurrent adnexal removal is required for that also, so that these are all difficult vaginal hysterectomy. And surgeon's profile is a fear psychosis is most important. Skill development and training is required for that, and of course the surgeon's dogma for that. Let us find out the large uterus. The large uterus, what is the optimum size for vaginal hysterectomy? There should be a limit for that. And that limit is variable from person to person. As experiences increases, the size also increases for that also. There is a recommendation, global recommendation that 12 weeks is the standard size for that. You have to remove vaginally. Beyond that, it is there. I always agree. If somebody asks me what is the size of the uterus to be removed vaginally, I say what is the size of the fetus that is removed vaginally? So it's about 36 weeks size. So 36 weeks uterus can be removed also by vaginal route for that also. So if the vaginal can admit about 3 kg baby, why not 3 kg uterus would come out for that? This is a fantasy. I cannot say that this is the thing. So this is the case I am demonstrating the multiple fibroid. In the first case, the large case, about 24 weeks size the multiple fibroid. So in the case, this is a paras women, para 2, vaginal delivery. And here we always use the, nowadays after 2005, I have left our suture and always with the vessel sealing devices, we adapt for that. And here the vaginal hysterectomy, the myoma, you go to the correct space, that is the secret, that is the key. If you go to the correct space, you find the correct space is there, it will be large myoma can come out without bleeding for that. And that is the important, the pathology of the uterus is very, very important for that. And this particular case, I'm telling that this is a case where it was higher up, and before normally the myomectomy should be done. After the uterine has to be tackled for that. But it's not possible always for that. But if the space is good, if you're going to the right cleavage, I think it can be done, removed very easily for that. So this is important, that debulking and myomectomy is very important for that. And therefore I say that the cephalocaudal versus transvaginal, I think this is important. Normally we say that it's a 24 weeks, means cephalocaudal, but the transverse dimensions is ignored for that. If the transverse dimension is more and uterus is 16 weeks or 14 weeks, it's more difficult than the cephalocaudal where there's a fundal fibroid of about, and it's a 24 week size uterus for that also. So that is important. So the sonographic estimates is very, very important now. The important machines are there, the mapping of sonography is there, so that you can map the site of the lesion and the volume of the lesion. Normally what is there in the sonography, there is a different misinterpretation of the dimensions. So the size is most important. The dimensions, say for example, if it is more than 10 centimeter, I always say clinical examination correlate the uterus about 20 weeks size for that. It's absolutely fallacious to find out a dimension. So the volume is most important, measurement of the volume for that. And then last is the uterine pathology. Myoma versus adenomyoma. Myoma like this, you can easily deliver it even if it's a big size. But adenomyomas is very difficult, and you have to do a debulking piece by piece for that also. And more so when it is transverse, the location, dimension, number, calcification, all the parameters for that, and therefore the mapping is very, very important for that. A posterior myoma is much more easier than an anterior myoma for that, and therefore the location is very important, and sonography can demonstrate all this. Now previous surgeries. Previous surgeries, earlier the cesarean section was the contraindication. Previous myomectomy was the contraindication. Previous Paderew's repair, amputation, or a previous Adnexal surgery was the contraindication for that, in vaginal surgery for that. Now no more. I think series set has given a lesson for that, and the concept is the lateral vaginal space is very, very important for that. The main problem of the previous cesarean section is the central dissection. The bladder is adherent for that. So go from lateral to medial, and even with the 2-3 previous sections. The first case is a 3 previous cesarean section with the myoma. And same philosophy, same technique I have adopted, that lateral vaginal space, and then come to the medial and separate it, and don't push it. The blunt dissection, don't do it. Always with the scissor and the sharp dissection in the proper cleavage, you go for that. And cesarean section is no more a contraindication for the vaginal hysterectomy for that. Even myomectomy, again the site of myomectomy, site of myoma there, and the procedure, whether it's done by laparoscopic myomectomy or an abdominal myomectomy. Normally in myomectomy, the adhesions are there in the distal part for that. So be very cautious about that. If there is an adhesion, see that there is no gut in that, and gradually with the vessel filler you can eliminate the problem. Paderew's repair or amputation, the main problem is their initial phase. To get the space above the cervix is important for that. Once you get it, I think everything is settled. There is no problem for that also. And previous surgery, adhesions, undiagnosed, endometriosis. In many cases, You do a vaginal hysterectomy, you have not suspected endometriosis, but the whole rectosigmoid is adherent for that. Don't convert it. You have to complete it vaginal route, and it's completed. There is no problem. Because earlier the concept was that open the A pouch, open the P pouch. No more. Don't open pouch. And really you go and Silas concept. Go closer to the uterus and fat belongs to the rectum and fat belongs to the bladder. Same principle we adopt in the vaginal case for that also. And therefore, you go closer to the uterus, rectosigmoid is safe for that, and you can complete the procedure. In fact, purposefully knowing that it is an endometriosis, I have tried a couple of cases vaginally also. You should not. You go for a laparoscopic procedure for that if you know that is a case of endometriosis. But I have tried for that, and the same technique I have adopted closer to the uterus, you can really deliver the case for that. Even some cases when I put a laparoscope, I didn't find anything. Whole thing is pasted. I couldn't find out the uterus and all that. Even with the lateral dissection, lateral pelvic wall dissection also, it's very difficult to get it. I started a vaginal, completed the procedure, put the laparoscopy and find out, and the situation, I think the bleeding or the ovarian remnants can be removed through that also. We call it, people call it total laparoscopic assisted vaginal hysterectomy. I call it vaginally assisted laparoscopic hysterectomy. I think VALH could be another form for that also. Now nulliparity. Nulliparity again, because of the lateral vaginal space is less, and therefore it is difficult. But it's not an absolute contraindication for that, because nowadays the suture, we are not using the suture, the space. For the suture we require a normal space for that. So the vessel sealer, they developed for that, starting from the sealer with the mechanical blade, or even with the shearer. Shearer is an Indian context. Indigenous is India, genius is indigenous. Shearer is a concept where you coagulate it, and the tip, the current strength is much more. And therefore, after the shearer has been there, the harmonic people are begging for that also. They've almost all surgeons have left the harmonic, particularly replacing by shear for that. So this is another case. I designed this by me, and this is by the German people, Martin people, where a coagulation is there, and then automatically, if you press it, there is a mechanical cut or a blade is there and cuts it for that. And without cut also, the current also cuts, and this is in case of the nulliparity, even if with the inadequate exposure, difficult lateral vaginal space, and lack of pelvic relaxation with the top tissues, it can be done for that. Now, about the adnexal removal. This is a case where adnexal removal, people say that when the ovaries has to be removed, don't do vaginal hysterectomy. You do it by laparoscopy. No more. I think normal cases is very important that adnexal can be removed. The only thing is that you hold the same technique, duplicate it with the abdominal or laparoscopy. Catch the round ligament first, separate it round ligament, and go and enter into the infundibular pelvic and remove it. And with really a good lighting and a retractor, it is very much possible for that. And more so with the vessel sealer, in comparison to the suture, it is much more easier for that also, and takes little time. And even if it slips also, the question of the coagulation serves the purpose for that. This is a case where hysterectomy, the case of a bilateral dormant tumor with abnormal uterine bleeding, and I started thinking of doing a 10 centimeter each on both sides, and dormant cyst with that. The other side says that salpingo-oophorectomy, which I have depicted about the separation of the round ligament and then going to the infundibular pelvic for that. And this is a case of vaginal hysterectomy with a dormant cyst, and you go the same technique you develop with that, and with the vessel sealer, you go for that. After removal of the uterus, I think the two adnexa in the upper pedicle, you catch hold of that and enter the, visualize the ovary, and there are two big ovarian cysts, the dormant cyst of about 10 centimeter diameter. At the upper pedicle, I have given a separate clamp for that and removed that because the space was not there. Don't think that I will suture it, and this is only for having a good space for that also. I delivered the uterus, and see the adnexa, whether the adnexa, what is the character of the or nature of the ovarian cyst, whether it is an endometriosis or it is a case of dormant. But endometriosis, right from the dissection, we find that it is not a case of endometriosis. You find a big dormant cyst, puncture it, reduce it, and then, and I think put a clamp, the same thing, and it's very easy to deliver it for that. So adnexa Removal means laparoscopy. Don't take it for that. The vaginal surgeons can remove Adnexal from below. Vaginal surgeons can remove appendix from below. Vaginal surgeons can remove the gallbladder from below, and any structures can remove from below, because it's a signature of the gynecologist. They can do it, access it for that. Now, second is about the surgeon profile, the fear psychosis, the factors. Will I be able to do it? There is no dissent. Uterine contour, dimension, mobility could not be ascertained. Uterine size is large. Previous surgeries are scar, nulliparous, possibility of adnexal. This is the fear psychosis amongst the surgeon for that. And I think develop your confidence and the surgical technique you develop one step by step, and things will be removed for that. And don't think that it's a blind procedure with inadequate space and surgical field. Many people believe that vaginal surgery is a blind surgery. No, if somebody is saying that blind surgery, he should discard surgery and enter into the medicine, not in the surgical profession. But the basic difference between us gynecologists and the surgeon, like Silas is not a classical surgeon. She is a combination, hybrid gynecological as well as a surgeon for that. And the basic philosophy between these two are that they cut and see, we see and cut. That is the basic difference for that. And therefore, see and cut. It's not a blind surgery for that. Don't cut and see and then manage the complications for that. Will I be able to do it? I will face complications. How to tackle? There will be hemorrhage, there will be rectal injury, bladder injury, ureteric injury, and others. I think in the medical curriculum, either in the postgraduate particularly, we lack in this particular training for that. We are very much apprehensive about the ureter. We are very much apprehensive about the bladder. Gone are the time we are very much apprehensive about the bladder. Now all the gynecologists are repairing the bladder if there is a bladder injury. They are not calling the urologist for that. But ureteric injury, they are very much apprehensive. Till today, they are calling the urologist for that also. And if there is a rectosigmoid injury, I think sleepless nights will be there whether to repair that or not. I think now there has been a lot of change. The prevention is important, and therefore the prevention is go closer to the uterus. If you go closer to the uterus, posteriorly, no rectosigmoid injury. Go closer to the uterus anteriorly, no bladder injury. Go closer to the uterus laterally, no ureteric injury. This is the mantra in vaginal surgery for that, to prevent complications. And if at all there is complications, manage yourselves with that. And these people will teach us. They have taught us, the neurosurgeons have taught us, and the GI surgeons have taught us. This is what, and I blame the curriculum of the medical curriculum is mainly responsible for that. When I was an HOD in my college, earlier there were less number of postgraduates. Almost around 6 to 8 postgraduates in the whole 3-year curriculum. Now the seats have increased. I've got 22 postgraduates in each year, 66 postgraduates. So now I've distributed them that in the 3 years postgraduate curriculum, 1 month in gynec oncology department in cancer center for that, 1 month in the surgery department and for the GI surgeon for that, and 1 month for the urology department, 15 days for the plastic surgery department, 15 days for the anatomy department. I think that is important. The fear psychosis will vanish if we do that. Now, I will not be able to complete the procedure. Need for conversion or laparoscopy. If you are not able to complete the procedure, you adopt the laparoscopy, or even laparotomy, you do it for that. So people are egoistic. They are egoistic. People will think that I am inefficient surgeon, I am not able to complete the procedure. That is in the mind, and need for conversion is important factor. Post-operative period will be stressful for me. Previous bad experience of mine as well as others, always in mind, and lose confidence. If there is one complication, one rectosigmoid injury, you forget. I will never do in vaginal surgery for that also. Don't keep it in mind for that also. So prerequisites for difficult vaginal hysterectomy. Pre-op assessment and planning is important. Anesthesia, the role of EUA should be done. In OPD, we have assessed the case and planned for vaginal hysterectomy. Again, examination under anesthesia, in the OT itself, you assess it, whether it's possible or not. Otherwise, you take help of laparoscopy or other gadgets for that. Special surgical techniques, the setup, the team, the anesthetist, assistant, paramedics, all are important. Gone are the time when the surgery was done, the quality of the surgery depends on the main surgeon for that. Now no more is the surgery of the team and tool by the gadget-oriented surgery. The quality of surgery is good. If the team and tool are good, then only the quality of the surgery is good in a gadget-oriented surgery for that. Now these are some of the equipments which is there for that. Prerequisites for vaginal hysterectomy. The hardly you see hardly 10 or 12 instruments are required. We don't display lot of instruments in the table for that. For vaginal hysterectomy, these 10, 12 instruments, even if it's a difficult case also, I do it for that. And I've customized this instrument, 10 instruments in one set, which can be autoclaved in the whole tray for that. And these 10 instruments are enough for that. And second important is the vessel sealer. The designing of the vessel sealer has really propagated us to do more and more difficult cases of vaginal hysterectomy for that. And that is important, vessel sealer. More so now with the Vitam, with the laparoscopy. People are used to do the surgery looking at the monitor for that. You do the same thing. And Vitam is the camera. You do an endoscopy camera in a difficult case for that and see the monitor and do the operation for that also with that. Or the surgicum is there in the camera monitor in the light, the surgicum is there and you can do that for that. And therefore, this is, and last but not the least, if there is a need for a laparoscopic gadgets, is there, you can do more and more difficult cases of vaginal hysterectomy. You are feeling confident that I'm ready. So laparoscopic gadgets, if the setup is there, I think you are confident of doing more and more difficult vaginal hysterectomy and complete the procedure in that particular case for that. So measures to be about fear psychosis, optimum knowledge regarding pelvic anatomy and altered anatomy. We know the pelvic anatomy. You have clearly demonstrated, Silas has clearly demonstrated pelvic. But the altered anatomy, if there is a surgery, if there is an infection, there is an altered anatomy for that also. And altered anatomy has to be known for that. And understanding the surgical principles and philosophy, the decision and dissection should be important. Proficient mentor, the need, acquiring a good technique, preventive surgery and managing complications. You always do a preventive surgery. Don't take a credit of doing complications and managing complications for that. And a urogynecologic and GI surgical exposure, as I have already told, endoscopic exposure could be also there for that. Therefore, a gynecologist who is trained in endoscopy will be better doing more and more difficult vaginal cases for that. An ideal surgical temperament should be there. The philosophy of the surgery could be there for that. And these are the four important things: the conviction, inclination, perseverance and indulgence, paving the way for difficult vaginal hysterectomy for that. And descent. If there is no descent, we can do it. Another time when there is a descent, we used to do a vaginal hysterectomy for that. Now the reverse is there. When there is a descent, they are doing laparoscopic repair. When there is no descent, we are doing a hysterectomy from below for that. There is a reversal. The science is changing for that. And access is not there. As you see, the equipment's designed and the equipment's access, they compromise with access for that. Size and adhesion. People say that I say that there is a mental adhesion in the brain of the surgeon rather in the pelvic cavity of the patient for that. Elaborate that. Man learns as he lives, and experience is the greatest teacher in the world. I feel that experience, as Silas reminded, there's complications. You learn from your own complications, you learn from your own mistakes and improve on that particular gadgets for that. And Swami Vivekananda has rightly said for that. And other factors like the surgical team, the efficiency, surgical tools, the limits of the surgical school, tools, surgical skill, upgrading the surgical skills and surgical technique, changing trends and changing techniques you have to adopt for that also. Handling complications, pre-op planning and mindset should be there for that. Which cases I will be expecting this complication for that. Pre-op assessment should be there. Operative technique, meticulous, non-complacency, tissue respect, assessment of altered anatomy, surgical timing. Don't look at the watch and do the surgery for that also. People take a credit. I think surgical timing, don't do and that I will finish it within half an hour for that also. Identifying your learning curve, more and more with the time and skill, you do more and more difficult cases for that. So preventive surgical techniques are the managing complications, early recognition of complications, managing it efficiently, and asking for help. Learning from experience. And one of the important things about the early recognition of complications, in the era of minimal invasive surgery like laparoscopy or non-invasive surgery like vaginal hysterectomy, the principle is that day by day, hour by hour, minute by minute, patient should improve. If the patient doesn't improve post-operatively, think about it, that says something important for that, particularly in the case of minimal invasive surgery, and that is the message we can give it. Preventing hemorrhage, tackling vessels, technique of dissection is important because the right space we can go for that. Coagulation, now the electrosurgery is there, bipolar vessel sealing devices are there. You can suture also if there is a difficult case, there is no problem, you can suture it. Tackling generalized hemorrhage, dissection in proper planes can avoid that. Aqua dissection, spray, ABC and medical management and targeted areas, you find out for that. Don't be complacent that they're bleeding, I will have put a drain and then come out for that. Drain is not for that. And you have to be absolutely very, very meticulous that, but in generalized oozing for that, I think as far as possible the primary arrest of the bleeding is there, then you can put a drain for that. But drain is not the approach for that. Approach to adhescence, recognizing the vital structures, recognizing the vessels, dissection in avascular space, dissection under tension, use of vessel sealing device, and finding the safety plane, both uterovesical and rectouterine. These are the two important planes of dissection and the lateral planes to prevent the ureter, as I have already told you for that. So the preventing injury to organs, again, I must reiterate again that bladder injury, ureteric injury, rectosegment injury and other vessels injury, the closure to the uterus is the key. Is the mantra, closer to the uterus, no injury will be there to either to the posteriorly rectosigmoid or bladder or the ureter or any other vessels for that. So have a surgical confidence, don't have an overconfidence on that. You should be crazed for surgery. From the beginning you should be crazed for surgery, and preventive surgery, mentor's influence and God's blessing, and the key for transforming operators to surgeons. There are innumerable operators in the globe, but very few surgeons. I think the time is there to convert these operators to the surgeons for that also. You mean that surgeons, what I mean by that, the decision and dissection should be there for that. And it's not a gifted thing. Yes, some things are gifted from the birth for that, but I feel that many things can be acquired for that also, and you can learn from your own mistake and update your knowledge and a clinical skill and a surgical skill for that, and transform yourself from operators to surgeons for that. So therefore, if you follow that, the big hole surgery, keyhole surgery and no hole surgery, abdominal hysterectomy, big hole surgery, keyhole surgery is a laparoscopic surgery, but no hole surgery is our vaginal surgery for that. And if you want to designate you as a gynecologist, and choice is yours, no dogma in science, be lovers of vagina, don't be lovers of umbilicus and all that for that. And every surgery, my teacher always says, every surgery is easy, every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. You have seen Silas operating just parallel and go and all that, and no bleeding is there for that. And the same other surgeons are operating absolutely bloody business and all that, whole of the pelvis for that also. So the surgeon is important. It's the surgeon who makes the surgery easy or difficult. All of you must be watching a surgeon doing very well. You can say that it's my left hand, I can do the surgery for that. Another surgery you done by surgeon, we say that in my life I can never do a hysterectomy for that also. So this is the importance of a good surgeon for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. And really I am honored to give this prestigious oration in the name of the great legendary teacher and a surgeon and academician, Professor Kaulgud.
Good morning, dear friends. And we are really happy to have Dr. P.C. Mohapatra for this wonderful subject, vaginal hysterectomy in difficult cases. And really it is a blessing for the freshers who are yet to learn and how to decide about the case regarding whether to go for a vaginal or in a mini lap or laparoscopic surgery. But I feel all the cases can be had through the vaginal surgery, and we have to really adhere to the hints Dr. Mohapatra has given. I really thank each and every of you to follow his guidelines, and really we can end up with vaginal surgeries. And whatever it is, the laparoscopic surgery if setup is there, we can really venture on any surgery, especially vaginal surgeries. Any difficulties, we can switch over to laparoscopy and finish up the things. That is really an advantage. I thank you once again, Dr. Mohapatra, please.
Thank you very much, sir. As we are running short of time, I request all the chairpersons to kindly keep their talks brief and crisp. And now, I request all the chairpersons to kindly felicitate Dr. P.C. Mohapatra, sir.
May I call Dr. Vishnu Priya on stage and to be ready by the side, please. Call the patrons of KSOGA to felicitate sir.
Rajeshri
And the
welcome
immediate
you
past
to the
president and past presidents of KSOGA and the president-elect.
Dr. Bharati Rajshekhar ma'am.
I am really blessed, we are really blessed today that the Guru of Gurus, Sir P.C. Mohapatra is there with us today. Sir, thank you so much for that brilliant lecture, for the demonstration of your, one of the finest surgeons in India. Beautiful vaginal approach. Sir, I request you to perform a little more for us now by, okay, let us read the plaque first, yes. Sir, it is my honor to read the plaque, sir. Karnataka State Obstetrics and Gynecology Association hereby confers Dr. P.C. Mohapatra the distinction of delivering the Professor S.R. Kaulgud Memorial Oration titled Vaginal Hysterectomy in Difficult Cases on the 35th KSOGA Conference, 2nd November 2025, held at Sri Siddhartha Medical College, Tumkur, in appreciation of his dedicated service to the upliftment of women's health and for being an inspiration to his fellow members. Thank you very much. We request you to stay on the stage for a few more seconds, and very importantly, I request the audience to have a few minutes of patience before the next Dr. M.G. Hiramat Yuva Oration can begin, which is a very important part of this conference. We'll come to that in just a few minutes. We have a very pleasant task of giving prizes for the Gestosis score competition. The Gestosis score implementation is the flagship program and the idea of Dr. Durgadas Asrana. This is a preventive strategy for hypertensive disorders in pregnancy. The scoring is purely clinical and is done through an app which has been developed by faculty from St. John's Medical College, Dr. Vishnu Priya and Dr. Madhva Prasad, who is not here. And he's here? Come, man. Come. Good of you. So tell about the app and the prizes as quickly as possible.
On behalf of the Gestosis Core Cell of KSOGA, which was initiated by Durgadas Asrana sir 2 months back, this notice was put up, and sir, as an encouragement, had promised that the highest users for 2 months will be awarded. So this served as an encouragement for both institutional and private medical practitioners. Next slide, please. So, so this technological tool has been used by 1031 patients in just a span of 2 months. So 1031 patients have benefited out of this, out of which there were 807 usages from private practitioners and 224 usages from medical colleges. We now call upon the prize winners of the highest usage. Can we have among private practitioners Dr. Manohar from Mandya with maximum number of usages, Dr. Swati Kishore from Karthik Consultation Center with 127 entries. From institution and medical colleges, can we have Dr. Nagabhushan from District Hospital Tumkur and Dr. Pooja K.E. from Saptagiri Medical College.
Thank you. See, my vision is to, we have to do something to the society. With that vision I started this, sir. Implementation of Gestosis score is one of the simplest thing we can at least reduce the incidence of preeclampsia. So What we did is we launched this project online through Dr. Sanjay Gupte sir and Dr. Hema Devaka, and the app has been developed none other than by the St. John's stalwarts, Dr. Vishnupriya and Dr. Madhava. Please download the app, and every day once you see the patient, apply the Gestosis score, and within 5th of every month send it through the website which Vishnupriya has already told. Once in 3 months we will assess. There will be 2 categories. One is the individual category, another is the institution, either government hospital or the corporate hospital or the medical colleges. And we have, to have some motivation, we have given some prizes. First prize of money 5,000, second prize 3,000, once again 5,000 and 3,000. And it will be given through the hands of stalwarts. And first batch is, we are fortunate to have Dr. Mohapatra sir with us, and I wanted this from his hands, so that it becomes a motivation for the subsequent doctors to implement this. I am very sorry for taking this time. Thank you sir, thank you.
Thank you, sir. A very big thanks to Dr. P.C. Mohapatra and to the scientific committee for giving us this time, and also to the audience for having patience. We have, yes, yeah. Name yenidu, Madhva? Already announced? Yeah. So we'll go ahead now. We have 2 conferences coming up by the next